Hello.
Hi, Chris is learning the back end today.
I know. I feel like Ethan. If y'all don't know, Rachel, we always have amazing staff members, IOCDF staff members, hanging out with us, and it's been Rachel lately. We've had a bunch of great people in the past, but it's really cool to help them out and take over. And so now, and I figured out how to blur my background a little bit. I'm normally at my office, but with the OC Southern California conference, I've been grinding on both ends. So I was like, I'm going to do it from home, and I can make I hate when it's so blurry that it looks like, but this makes it like a soft ambiance. So
I love it.
anyway,
I'm at home too. As you can tell, I have had sick kids and all the things. So apologize, but I am here and excited. So
I know it's so funny. I saw a mom post the other day, and she's like, I have two jobs. I'm a mom and I'm sick. So apparently if you have children, you're sick. That's just kind of like
I have like 10 jobs.
Well, welcome everyone. It's a beautiful day. It's myself and obviously my host too. Introduce yourself, darling.
Liz McIngvale, so good to see you. I'm the director of OCDI, and Chris and I have been doing live streams for, I don't know, has it been like 3 years, Chris?
Yeah, because I came in a little bit later doing live streams. So yeah, 3 years.
Somewhere like 3 years. And Chris and I used to do every week live streams, and I've kind of tailored back crazy life with 4 kids, and have been so excited and love watching Chris and all the amazing work he's doing and guests he brings on. But I also am like selfishly so excited when it's the first Wednesday of the month and we get to get back on together.
I know. I always look forward to it. And I love that we picked the first Wednesday of the month because I feel like it like kicks off the week and sets things up. And I love working with you too, because I was thinking about it the other day. I was working with a client and they had worked with another provider out of state that I really liked, but they moved to California, and it's hard to be licensed in California. And they're past therapists too. The dog's like, I want to be part of this live stream. But their last therapist had been OCD, and their psychiatrist doesn't have OCD. But my client was just like, man, everybody that works with OCD seems to be so passionate about this work. So I love that. I love that you're passionate. And I love that we're here. As always.
And I have a lot of thoughts lately, just because I feel like there's been you and I have talked about this for probably like a year and a half, about the misinformation of ERP and what has been happening and what hasn't online. And so, yeah, y'all know, like, we get passionate and excited because we want to help people with OCD. Like, this is never, Chris talks about this a lot, but we both do, and we share the same sentiment that this is never about our agenda or about what we can push or, what we think is important or something that self-serves us. This is a free thing that we do to give back to the community, to provide education. And we would just want to make sure it's always the right education.
Yeah, I was really inspired. I was at the BTTI in the advanced forum for, it was the BTTI on pediatrics in Long Beach. And some great people were running it. I had the honor to present with one of my clients. It was really cool. My client and his parents came and presented a case on disgust-based OCD, generational OCD, like subtype switching and other things. But I think what I said when I was there is like, it's so awesome to learn from people like Marnie, Michelle Massey, people like Eric Storch, just people that are really leading this field. And I think Darlene Davis was there. I told her she was so good on the wrap-up panel. And everybody was awesome. The cases were great. But I think what I always want clients, what I feel like it's our ethical duty to do is, like, I love learning from the people that are researching. My mom's so impressed by you, by the way, because you're going to be our guest on our family and loved ones group on Saturday. And so she was looking at your bio and she's like, wow, Liz has published so many research pieces and papers and stuff. And so it's just like people like you doing research. And I think, we all hopefully have good intentions in this field, and we just want to provide you guys with what's working. We know so many people. I was working with someone who had a talk therapist for 7 years who didn't make a crack in their OCD, and the sessions were really just reassurance that she wasn't going to harm her family. And so, I think we're all passionate. We just don't want you all to be stuck in years and years of invalid service,
Exactly. I think that we come from a different stance a little bit, in the sense that like we both have lived experience. And so our passion isn't just our profession, it's also like our personal life, right? Like this is what has served us, has kept us alive, has allowed us to be alive. It's what also allows us to thrive. And we just know everybody with OCD deserves that. And I have a lot of thoughts, and we'll hop into most of them, probably not all of them, because they're not all appropriate for a live stream, about just what is going on and some of the misinformation, but also like, how do you navigate therapy? How do you know, how do you know or think about what to expect, and what should you expect from treatment, I think is really important. And yeah, I'm so excited for the Saturday live stream, but I'm also so excited for the next Saturday for the OCD SoCal conference. So Chris, why don't you share some updates on all the things going on before we hop in?
Yeah, so there's a lot of good stuff coming up. So if you are a family member or a loved one or a spouse or somebody who is, I don't know how you put up just I'm learning all the back end stuff. I don't know how you.
Here's our learning that everybody gets to learn with us.
Oh, I can post.
How do we put up a banner?
So there's a couple different things I want people to know about. So if you are a family member or someone who loves somebody with OCD, a spouse or a clinician, this Saturday, every second Saturday of the month, it's a labor of love that my mom and I do, absolutely free. We run a free loved ones, family member, spouse support group. I'm excited to announce that Liz McIngvale will be our guest this Saturday. So it's a 2-hour support group. It's from 11 a.m. to 1 p.m. Pacific Standard Time. It gives you an opportunity to come and get resources as a loved one supporting. We've had people like you and Nathaniel Van Kirk and Alec Pollard on the group, and it's been amazing. So all you do is just email that email right there, info@ocdsocal.org, and then that allows you to go ahead and email us and get on the email list. It's free to be a part of a group. The following week, you are going to be one of the speakers at the OCD SoCal conference. So we are putting on a big 2-day conference. You can go to this site and get all the information to register. But Liz McIngvale is going to be a speaker. So OCD SoCal is an official affiliate of the International OCD Foundation. And we are putting on a 2-day conference. And we're really excited because Liz McIngvale is going to be one of the speakers. I am so
we're really excited because of the lineup of speakers. You have like it's always like the all-star lineup of just these like incredible speakers. And what I love, Chris, is that y'all do such a great job of not just bringing together like all the topics people want to hear and the speakers, but like you combine them together. You have these like expert panels that are so amazing. And like I know we're doing the closeout with me, you, and Pat, and a couple, it just like, it's so cool. Make sure y'all check it out. And I love the fact that it's accessible to everybody. It's online. It's not like you have to fly there, and you get to just see and learn and be with all the who's who, so to say, in the OCD world.
Yeah, so please come out. It's low cost. We have scholarships available. If you go on the website, you can email us at scholarships@ocdsocal.org. And that way, it's no cost. We don't ask questions, but we have some incredible people: Liz, Patrick McGrath, Michelle Massey, Marnie Jacobs, a lot of really incredible people, Eric Storch. I was talking to Katie O'Dunn this week, and we are so excited to make sure that you know that there is a Faith in OCD conference. As you know, scrupulosity, I was talking about it with a client. Scrupulosity is one of the first on record cases of OCD. It was Martin Luther who created the Lutheran Church, and OCD affects people's faith. Scrupulosity is a major subtype. And so a lot of people are really struggling with how do you balance OCD treatment and still respect your faith. So it's an incredible conference. Please check out all the conferences IOCDF has to offer. So if you go to iocdf.org, I'm going to put that up there because IOCDF has everything. We'll do that. Go to iocdf.org. You will see a conference tab. So they have the Faith in OCD conference. And then what I'm excited about in December, what a lot of people may know is that clinicians need to earn continuing education credits. And I actually don't complain about it. I really do like it because IOCDF offers so many continuing education credits for clinicians. And in December, they are having a forum, a day of learning. And there's going to be your law and ethics continuing education. But what I'm really excited about is there's going to be presentations on adjunctive and second line treatment. So for people that are clinicians and newer and haven't gotten training in different types of treatments and stuff in addition to ERP, it's going to be great. So as always, go to iocdf.org. The affiliates, it's not just OCD SoCal. I saw that OCD, I think South and Central Florida is putting on a conference. The Midwest just had a conference. The IOCF is pairing with a lot of big organizations, so a lot of stuff. So keep in the loop. Really quick, we want to make sure that you know that if you are in a crisis, please, Liz and I are here to give you resources, education, support, community. But if you're really struggling, please, make sure that you end up going to your local emergency room, dialing 988, 988, lifeline.org, or 911. And you can always find a provider near you if you're really struggling. It's so important to find a clinician that is trained in OCD treatment, understands OCD, but also crisis management and can support you. So please check that out. And then last thing I'll say is shout out to everybody that's joining us and saying hi and hanging out with us. It's always good to have our community. I see people liking the live, like it, share it, follow the IOCF on all platforms. The IOCF is always tweeting out. Well, I don't know if you should tweet anymore, but at least posting on Facebook, LinkedIn, all these different sites to give you resources. We have people from all over. We have people from Japan, which is always good to see. We love Lewis saying hi to both of us. We got Texas, your hometown in house.
Woo-hoo.
I always love Athens, Georgia, because I'm Greek and I have
Right.
to let Liz know. And so Athens as well.
Surprise. Did you know Chris was Greek? You know he likes Greek food?
Yes. Buttercup is coming to the online conference next week. We really appreciate it. I love that we have international people. We have Slovenia here, which is really, really exciting. So thank you so much for everybody to be here. Lewis has their ticket as well. We're really excited. And then I love this. Gail is in Cape Town. So we have people from all over. I'm so excited. But yeah, what I want to jump into, kind of to go off of what you were saying at the start, how do people know they're getting the right treatment? Because I think there was pluses and minuses when you and I were getting treatment. I think besides obviously the talk therapist who didn't really know stuff, there was like one source of getting information. So my mom was able to find like, oh, there's OCD specialists. This is the treatment that they do, ERP, which is under the CBT umbrella. And like, these are the resources. And although that can feel limiting, at least we weren't kind of chasing things around. How do people know that they're getting the right care? And what should they be expecting? That's the other question I get a lot from people that email me around the world. They're just like, I've heard your story. I'm in an OCD treatment specialist. Is this even going the way it's supposed to go?
Yeah. And it's such a great question. And it's a loaded question, right? I think that first of all, it's important for us to know, and Chris and I've done many live streams on this, is talking about comorbidities, right? That a lot of people with OCD are actually struggling with more than just OCD. And so the reason I say it's a loaded question is it'd be great for me to say, okay, here's OCD, let me put in a capsule and like, that's all we're going to treat. And I could tell you, here's exactly what you should do. But the reality is that for most people, it's a lot more complex than that, right? There's comorbidities going on. There's secondary gains that might exist. There's all sorts of things that need to be interwoven into OCD treatment. And I say that because one of the biggest misconceptions that's out there right now is that, people who are ERP providers like me and Chris, all we do is ERP. And it's like, well, no. Yeah. Is it majority of what we do? Of course. Is it what we specialize in? Of course. You can't be a leading expert in multiple things, right? You hone in, you focus in, you have a specialty area. But it certainly doesn't mean it's all we do, right? My patients don't show up without depression, without comorbid anxiety disorders, without other comorbidities, without borderline personality disorder. Like all of our patients have different comorbidities, and we need to have a toolkit of interventions that, by the way, should all be evidence-based for the different things anyone's struggling with that we can grab and pull and use from. So I want to just start by saying that. The second piece is I want you to think a lot about what defines an expert or a specialist. I think John Abramowitz put this once, and I think his thing was like, you need 16 years in the field to be considered a specialist. And I think what he was trying to say, don't quote me, we could have him on, is it isn't just about 16 years doing general therapy. It's 16 years dedicating your career to research, education, understanding, training, and clinical work specific to that intervention, right? And so how could I be an expert in multiple things? Like that would be, you know, maybe I could be an expert in 2 things if I've practiced for 30 years. Like but again, it's really honing in and having expertise. And I'm going to go on a tangent because y'all know I can't not, but I think one thing I'm struggling so much with, Chris, is that there's just so much misinformation on the internet. And this goes back to your original question, which is that when you and I were first sick, that was a long time ago, and there wasn't a lot out there, right? So our parents, like my mom didn't even find IOCDF. It really wasn't very known. It was a tiny little organization when I was first diagnosed 20 plus years ago. And so you didn't actually know where to go at all. And then when you did find the foundation, we found the foundation probably like 5 years into my treatment. That is when we got plugged into the conference, met Dr. Janicki, started meeting these leading experts, and really gaining a lot more education and insight and awareness around OCD treatment and all the things. And I think that for, I don't know, a decade plus, there wasn't a lot out there besides IOCDF after that, right? Where it became and still is the leading resource, the leading educator, and just such an incredible organization that guides individuals on a path to evidence-based effective treatment. The downside with the internet, well, let's start with the plus side first, is people know what OCD is now, right? When I was first diagnosed, people didn't even know what that acronym was. Like we have come so far. When I first started doing OCD advocacy when I was 17, nobody else was talking about their diagnosis, about their OCD. And now we have hundreds of advocates and influencers and individuals that are sharing stories. And that's awesome. Like there is so much to be said for where we have come in terms of access to education, stigma reduction, right? All those things. The downside is that we can't manage or control any of that messaging. And I want to encourage you to be weary of some of the education and information you receive online versus in the office with a licensed clinician who is a specialist. Again, not a licensed clinician who just started, not somebody who's providing recommendations based on their lived experience, because that isn't how Chris and I or anyone should treat patients. I want you to get expertise that is guided from leading clinicians and the leading research, right? IOCDF, we just put that up there, but we have posted the treatment guidelines, and these guidelines weren't put out and published by Chris and I. These are guidelines that we took the leading experts in the world. There was a review panel, and they really dug into the research, the evidence, the background to develop these guidelines. And so I want us to be really thoughtful of, am I taking education and guidance from somebody who's kind of giving it flippantly, or from somebody who is only posting things that are truly rooted in science, in evidence, and in appropriate information? And so I'm going to get to that in a minute of what I mean by that and what that looks like, because you know it's important for us to talk about it openly, and it will lead us to where we're going today, which is, what is the goal of ERP and what should it look like, and what is the problem with misinformation? But Chris, tell me, like, from your stance about some of the changes and shifts you've seen in education and awareness, the beauty of it, but also the scary side.
Yeah, I think the beauty of it is, I mean, I traveled 4 hours round trip for my treatment because obviously down here in Southern California, there's always traffic. And it was long days. You know, I have both obsessive compulsive disorder and body dysmorphic disorder. I ended up after 6 months being on medication. So I had my OCD treatment, my BDD treatment, my medication, my support group. So it was long days. My mom and I always fingers crossed that we were able to get everything on Wednesdays. That's when I went. We were able to get everything on the same day, so we didn't have to go up multiple times. But I think the good thing now is it's a lot, easier to find a provider trained in exposure waiver response prevention, trained in CBT, understand how to diagnose OCD, know the signs, the symptoms, the subtypes, know a little bit about medication, or at least how to find you a provider. So I think that the conferences has grown. Thousands of people are coming to the IOCDF annual conference, both online and in person. People are getting resources. IOCDF are putting out all these virtual conferences like the FaithCon, the BDDCon, right? So there's so much more resources and information. I think what's hard is we don't have a regulation system. Obviously, I'm biased and always send people to IOCDF because I really trust the staff. I trust the scientific and clinical advisory board. I trust our board to make sure that the things that go up there are going to be the things that are really proven to help people. I think what's hard is I see a lot of stuff that gets put out there. Some of it is absurd, right? We talk about the guy with celery juice, or I saw, not willingly, but when I was scrolling on Instagram, a podcast, and the guy was saying you could cure all mental health if you just stop eating gluten. I was like, I tried that and I just became miserable and mad and ate pizza as soon as I could. So the idea behind it is it's difficult to know what is good and what isn't. And I think obviously, it's kind of like the information for general health. People have a doctor, but they can't see their doctor every day, but they can scroll every day, and they're getting all this health information about cardiovascular health or dermatological health or how to take care of your gut. But we don't know who these people are. So obviously, I always trust when people have a governing body. I know in Texas, as well as California and worldwide, there's a governing body that oversees all us clinicians. And it's not perfect, but at least it can help. But I think one thing I'd love to see in the field, I think the closest we have to it is just looking, is somebody BTTI trained, or are they on faculty, or do their staff have training from a reputable source of ERP training, of adjunctive treatment training? Just, is there something that shows that this person has really dedicated a lot of time on it? Because you should be getting relief. I think that's the thing that always gives me pause as well, is if somebody has been in treatment, they're like, Chris, I've been in treatment for 3 years and I'm still suffering the same time, or mildly making progress. So I think that's key as well. Treatment should be working, and you should see some relief in the first 3 months, or in a higher level of care sooner than that.
Yeah, so let's talk about that. So I want us to talk for a second about what does progress look like and what should you see? Because I think that this can be real confusing for people. And actually something we're going to talk about in the family support group this Saturday is like, how do we understand when we're making appropriate progress and we're actually progressing in treatment, versus we're stuck in our recovery process? And ERP is what people would often say like isn't working, but it's not necessarily that ERP isn't working. There can be a lot of other factors that we'll talk about today. How do you gauge that? Like, how for you, Chris, with your clients, like what does that look like? And then I can go first, up to you.
Yeah, I think one of the misconceptions about ERP, because it is predominantly behavioral, is that insight doesn't happen. And I was having a really good conversation with a client yesterday, and he's like, how do I shake this thing? And he was kind of asking me, how did I shake this thing, right? And I think when you kind of finally hit that point that you recognize that what you've been doing has not been serving you, it's been maladaptive and not helpful, but you're at that point of insight that you can say, I can walk away from this, right? So, I'm going to change subtypes because it's a real client, but let's say, somebody has a fear that they're going to harm people, and they really do these kind of like counting rituals in their head to neutralize those thoughts. When people have done successful ERP, they've dropped the compulsions, they have insight, and then they make that decision. I'm not doing this anymore. I am not going to sit here and try to quote unquote protect my family from doing all these mental rituals. I'm taking the risk of walking away, engaging in life, dropping sort of my contribution to OCD. I know I'm going to still have thoughts and feelings, but I'm no longer going to engage. So if treatment's working, you should be getting insight, understanding the disorder and how it works. You should start to see that, hey, by not contributing through mental and physical compulsions, I'm actually starting to get some relief. I think everybody thinks that they're going to drop their compulsions and have a panic attack and break down. The opposite happens. You're teaching your brain that your environment is safe and you can trust yourself to manage difficult moments. So people should be getting insight. They should see a relief in general anxiety throughout the day. They should notice that the urge to do compulsions is less, and they should start to see their life pick up again. They're starting to read again, or walk their dog, or have coffee with their friends. So the good thing, and why I love this work, is it is kind of quick acting if everything is going right. Not overnight, but you should start to see relief and success in those first couple months of doing treatment.
Exactly. So, what you should see is that in as little as 8 to 12 weeks, you are at or seeing yourself get to a drastically different place than you were when you started. And one of the things Chris talked about that I think is a huge misconception is so many people have provided a lot of misinformation online lately that ERP means you have to live with uncertainty forever. It means you never have to know. It means you need to accept your worst case fears. It means you need to be okay with who your OCD tells you might be. That is not true, you guys. ERP should actually provide clarity. ERP should actually rebuild trust in yourself. Now, does that happen in the first couple weeks when you're starting to do ERP and diving into treatment? Of course not, right? That happens with time, and we need to let go of having clarity, let go of having certainty while we're doing the treatment. But at the end of the treatment, you actually should have clarity that you aren't those fears, that that is your OCD, that that is not you. You should have clarity about who you are and trust in yourself. And I think that's so important, because I get so frustrated when I cannot tell you the number of patients I see who have gone to a OCD specialist who's really doing kind of an old school traditional ERP habituation model, and they aren't helping, and they are kind of treating ERP as like fear factor, and let's just see how triggered we can get you. Let's just see how uncertain, see how distressed, and that's the point of treatment. That is not the point of treatment. The point of ERP is we have you engaging in ERP so that you can get closer to your values, so that you can get back to the life you want to be living, so that you no longer have OCD making decisions for you. It is not just to see if we can dysregulate you. That's traumatic. That's not treatment. They're two different things, very, very different things. The other thing I would encourage is we really want to be encouraging what we call measurement-based care. So we really want individuals doing, for like OCD, you would do the Y box. For depression, you'd probably do the PHQ-9. For anxiety, you'd probably do the GAD or GAD-7 measure. We want you doing those measures frequently. So we want you doing those measures when you first arrive in treatment, and then often every couple weeks or so. At our program, of course, we're doing it weekly. We're in a residential program, and different people are doing cadences, because not only do I, as the clinician, and you as the individual, want to see and believe you're getting better, but we also want to have data that backs that up. You know, one thing I tell my patients a lot, which is not what they want to hear, is that sometimes what you want is not what you need. Right? Most of us with OCD would want a talk therapist, right? We would want somebody who's going to reassure us, who's going to make us feel better, that we're going to go to therapy and we're going to leave feeling good. But it isn't actually what we need. What we probably need is somebody who's going to push us, who's going to challenge us, who's going to trigger us in an empathetic way that makes sense, and that we have trust with them, but that can move us forward. Because one, even though it may not be what we want in the moment, will actually decrease our OCD and increase our life. The other one will increase our OCD and decrease our life, even though it'd be giving us what we want in that moment. So I think ERP and therapy is tricky in different ways, but it is the most rewarding, dually functional relationship with your clinician that is just so amazing. Because if you are able to get effective ERP, you will see how your life will change. And, you know, there's a lot out there lately on like, you don't need to do ERP to get better. You know, you can talk your way out of it. I'm going to call that out a little bit right now. You know, be really careful, you guys, on what language you're spreading on the internet, because I've never met somebody with OCD in my life who hasn't already tried to talk their way out of it, right? That's what you do naturally. You try to convince yourself it isn't true. You try to seek reassurance. You try to understand it, and it hasn't worked. And so be really cautious about what we are promoting as first-line evidence-based interventions. But more importantly, I worry less about those people that are pitching different things that I don't agree with, and more about those of you suffering with OCD. Start with what we know works the most. ERP is the most effective intervention. It works for a majority of people. It drastically and significantly decreases OCD symptoms. And so we want you to get with the right person. However, what I will say is that 3 people can say they're doing ERP, and only 1 might be actually the right one who's qualified and a fit for you. So Chris, let's talk about that. If I'm looking for an OCD provider, or for my daughter or whomever, what should I look for? What would help me say, okay, this person is better equipped than this person?
Yeah, I think there's a lot of factors. I mean, I would say one thing that you already touched on is I don't want to go to a foot doctor who works on a foot once a month, right? Like, you want to find a treatment center that OCD and related disorders is really their bread and butter. And then I think it's really about finding the right level of care. If you're watching this and it's really difficult to take care of your daily functioning, it's hard to go to the bathroom, to shower, you're not leaving the house for days at a time, you've had to drop out of work and school, you don't see your family often, that is better handled and suited at a residential treatment program where you can have round the clock care. If you're not quite there, but you're really still suffering, and maybe you're dropping out of school or work, or OCD is really impacting 5 to 6 hours a day, a partial hospital program or an IOP might be better. And then one-on-one or group therapy works for people with more mild, slightly moderate cases, and really kind of doing the work. So I think finding the right level of care. But remember, this is a person you're going to be opening up to about extremely taboo things. So you want to make sure there's a connection. I that's one of the talks that I'm doing with Patrick McGrath, Allegra Castens, and Kim Quinlan at OCD SoCal's conference is like the power that therapists have, right? Like there should be a connection. And I think a lot of times when we get trained as therapists, sometimes it's like, you're not supposed to be human. Well, that might work for certain modalities, but people with OCD are about to open up about fears of harming their family members, about, being blasphemous to the crucifix or hitting people with their car. And you want to make sure the person sitting across from you has empathy, cares, and training and understands. And then lastly, I'd throw out there one thing you mentioned earlier is if you're dealing with other conditions at the same time, severe depression where you're not eating, it's hard to get out of bed, you have ASD, autism, or you are dealing with PTSD at the same time, really make sure that the provider either feels comfortable with addressing those conditions, or like myself, at an OCD clinician and a BDD clinician to really kind of navigate those two disorders. So I felt like I had a team. But I think, OCD is a language. And that's one of the feedback I get from clients. They're like, I can tell OCD because you're talking my language. If you feel like you're educating your provider, if your provider is not starting with, we put up the treatment recommendations, they're not starting with those frontline things. We understand, look, Liz and I are trained in modalities beyond ERP. We understand if like ERP alone isn't the answer, right? Clinicians definitely, I like to post that Allegra Castens did last week. She's just like, look, like ERP is frontline and there's other modalities that help, but like we shouldn't be abandoning the things that work. So I think it's important to make sure that people are kind of speaking all the things that Liz and I are speaking today.
And what I want to say is that you guys, ERP, I think a lot of people think ERP is archaic, and sometimes that's because you are with an archaic provider. And I'm serious when I say that like, there are providers who still do ERP the same way they did it 20 years ago when I first went to treatment. I don't do anything. I shouldn't say that. There's some things that are similar, but like the way our treatment looks for individuals at the clinic is completely different than the treatment I received. And by the way, the treatment I received still saved my life, but it had a lot of issues. It had a lot of errors. It wasn't values-based back then. We didn't understand the research of Dr. Wadsworth and Pensiani on values and justice-based ERP. We didn't understand that you could actually get to a place of full freedom. We understood OCD back then of like functioning, and we do enough, and there wasn't the integration and core fear work. And so ERP has drastically improved and shifted and changed over time. And what I will tell you is that if a clinician you are working with has not been specialty trained. And so what I mean by that is I want to know, where did they get their training? How many years of experience did they have? Have they done intensive treatment with patients? Have they done higher levels of care, IOPs, PHPs, residential levels of care? That's where you get the most intense hands-on training. And so be really thoughtful about what background and training does my clinician have, or do they just like have a following and have their own personal perspective of what treatment should work or what treatment should look like? And is that enough? Is that actually going to get me where I need to be? So I want us to really be thinking about that. The second piece is actually funny because Chris answered it on his own. Sorry, I'm trying to move out of the sun. Is Chris said, about higher levels of care, because it's going to be two things. Like, number one, what is the specialty training and background that someone has? But number two, which is really important, is this the right level of care? It would be unethical for me to treat patients in residential that don't need res. It'd be unethical for me to treat patients in our day program that don't need a day program. I step patients in and out of care all day long and down before they thought they were going to step down, because they don't need our level of care anymore. You should only be in the highest levels of care when you need that highest level of care, right? Do you need round-the-clock support? Do you need support with ADLs? Are you unable to do exposures independently, right? Some of those questions we want to think about. Also, it would be unethical of me to keep someone in the program that's primary presentation isn't best treated by ERP. because we are an ERP specialty program. And so when you're looking at higher levels of care, some of them say they treat OCD, but you're actually with a cohort of lots of different disorders and diagnoses and treatment providers who really specialize in more generalist practice than OCD. That's not going to move the needle. So that would be unethical. It would be equally as unethical if Chris had a patient who needed res, but continued to just see them on a weekly out basis and was convincing himself or the patient that, hey, we'll get there, we'll get better, but the patient's stuck and they're not getting better. And so again, it goes all ways, right? Chris and I can both be really good clinicians, but if the patient's not in the right level of care for either of us, mine's too high, Chris's is too low, the patient isn't going to get better and get the help that they need, right? And you could say, well, Liz, why would it be dangerous if a patient's in a higher level of care if they don't need it? Well, I'll tell you why. It creates codependence. It creates this belief that they need this round-the-clock care to do exposures, to do better. No, our goal is that we start at a higher level and we slowly taper patients off because we want you to become fully functioning, independent, successful individuals and contributors of society. We don't want to create individuals who think that they can't do this on their own, right? Because we're behaving as though they can't do it on their own, even if they can. So just there's a lot of nuances to think about. And so be cautious when people are just talking negative of ERP. Really sit back and say, where's this coming from? And why would this be the case for me? And is there actually ways I can adjust ERP to be more successful versus throwing ERP away? Because it still remains by far, hands down, eons away, the gold standard, most effective treatment for OCD.
Yeah, somebody's saying amen, Liz, amen. Yeah, and that's the cool thing too, is I think that people that aren't paying attention think that ERP is exactly the same. And one thing I talk to clients about a lot is like, I've had people come to me that are like, look, I tried ERP 20 years ago, it didn't work for me. And it's like when they describe it, right, it does sound pretty harsh. And I was so fortunate that my clinician never treated OCD the way that some people said, right? So I think it's giving it another try and asking the clinician, like, what are some things that you do differently now that maybe the field did 20 years ago? I mean, like you said, you and I have done so many talks on this topic about you're not just sitting there and accepting that you're going to kill your family. That's not OCD treatment. That's not even really ERP, because somebody can't ever get to a point that they're like, all right, I'm going to kill my family, right? It's being able to recognize that you're going to have those intrusive thoughts about that really, really unsettling topic, and you feel desperate to like prove to your brain, I would never do that, and argue back and forth, but that conflict is keeping those thoughts. So it's pulling back your contribution and saying, look, like, brain, you're telling me this horrific thing, but what if I don't keep giving it attention? What if I don't keep engaging in it? What if I don't avoid my family, right? So I think it's very different than what some people think. Sometimes people tell me what they think ERP is, and I'm like, I wouldn't be an ERP therapist. I do a lot of stuff outside the office with clients, and I'm like, I would have been arrested if I was doing the things that people are talking about what ERP is doing.
But by the way, Chris, people are still doing that treatment.
True.
Like they're like, I think we're like, oh yeah, that's old school ERP. It's like, well, it is, but people are still doing old school ERP. So when I have clinicians come to me and they're like, the therapist was making me throw rocks at my church. I'm like, well, why? They're like, I don't know, because I have scrupulosity. It's like, that doesn't make any sense. Like, there's no, why are we doing that? So anyway, lots of thoughts. I know we have lots of questions and we just chatted forever. So let's keep going.
I'll say one last thing, but I want to go to the questions for sure. I love Dr. Jen Yip was on this, and she said one of the things that she thinks that isn't helping people with ERP is if they're doing stuff like that, throwing a rock at a church. Yeah, if that person can't envision why they're doing something, they're not going to see value in it. Shout out to Nathan. He is going to be starting ERP. So awesome. Happy with him. It always breaks my heart when I see things like this, Liz. I mean, we can't control it, but I wish OCD couldn't affect people until they turned 18. Well, I wish it affected nobody, but it always breaks my heart when it's kids. So,
although I don't know, I my first signs and symptoms were before 12, and 12 was when I got treatment. Yeah. What I will say is that the benefit of that is that as a parent, you can help find the right treatment. And I think parents are more equipped to help get somebody to the right ERP treatment really quickly than an 18-year-old is on their own. So there's benefits to it too, right? Which is that, like, as a parent, they're a minor, you can make them go to therapy. You can also hand select the best clinicians versus when you're 18 and you're just like looking at a college campus for who to see, and you end up with someone with that expertise. So also, the earlier we intervene, the better. So, the
Yes.
sooner the better. All right. So let's start with Janice at 11.
Oh.
You want to start there?
No, I just wanted to say real quick. The reason I wanted to put Debbie's comment up is because I think a lot of times when people have OCD and other disorders, they think that means they can't get better, and it's like, no, a lot of us have other things.
Yes.
Give this person hope, Liz. Give this person hope. They've been in ERP for 4 months. They're at about 40%. They have a treatment plan for a year. Is it possible to be to have some recovery after a year?
100%. So, we see recovery after 30, 40 years. So absolutely. And what I will say is 40% reduction is great. Like, we want to look at that as like, okay, that's awesome. But what I want you to do is sit back and say, what is holding me back from that other 60%? Because once we understand, you guys, like the ground rules and ERP and what it should look like, most of us know what we are holding on to or where we're holding back or safety behaviors or rituals we're still doing that are keeping us stuck, that are keeping that 60% alive. And so I really want you to sit back for a little bit and say, okay, what is it that got me to 40% better, and what is holding me back from that remaining 60%? And then dive in with them, with someone else, on your own, right? I can't tell you the number of patients who we treat that get maybe 40% better, but they understand what they need to do, how they would need to do it. It's just up to them to go do it. And then they go start living their life, become more motivated, become more willing, and boom, before you know it, they're willing to like dive in and do that remaining ERP for what's left. So it is never too late. Treatment can work at any point in time. And it sounds like some of the basics, but I'd want to dive in. I want to like dial in a little bit of like, what is it that remaining 60%, like what's going on? Can I throw something out there, Chris?
Yeah.
And sorry, IOCDF and Chris, I'm throwing this on both of y'all, and I don't know if you can do it, but I would love for us to do at least one show a month, or we could make it our show, that it's like a dial-in where we could actually have people like talk through in real life. Like, I want to know about the 40% you got better, and then why you're not getting better with the 60. And I want us to like break down together what's going on so that we can help people see the way you can fine tweak, adjust all the things you need to do with ERP to get it better. So that's my push. Let's do like a couple live Zooms. If not, we can do them through OCDI Texas or somewhere. But I just think it would be so useful for us to really hear real live examples from other people and hear how I would walk through it, or you would walk through it, and what we would do different and why.
Yeah, I think one of the things that I feel like years of doing this has given me is that it's like if we're there, but we're stuck somewhere, it's like being able to really figure out like, what is that blockade? What is it? Is it just like, this is your pace and you need more time? Is there something co-occurring? Is there family enmeshment? Like, are people reading stuff online so then they're having second thoughts? Like, what is it, right? Is it white knuckling or secret compulsions? Is a medication change that needs? But yeah, that's part of treatment too, is making sure, and that's why you were talking about doing the different testing throughout the program at OCDI so that you could see, is the person making clinical improvement?
Yeah, absolutely.
We'll figure it out. That'd be cool to do. Yeah,
we'll do it one way or the other. Because I think it'd be really fun, and we could keep it anonymous by doing just call in, or people could share whatever people want. So let's jump to Janice's question, Chris. So my son is currently in ERP therapy, and it seems he takes one step forward, but always two back, and feels like he's never moving from square one. He's had about 11 sessions along with medication, and he's still giving into his compulsions almost every day. I know everyone is different, but how long should we remain with the current program till we try something different?
Yeah, Janice. I mean, I would say, like, if your son, let's say your son really does want to get better, because I think that's always kind of the first thing. Well, let me take that back. I don't think anyone doesn't want to get better, but if your son is like, hey, mom, I really want to do treatment, I really want to get better, and is going there willingly, because I would argue like my most difficult clients are actually not severe clients or clients with multiple co-occurring. It's really someone that just shows up. They're usually brought there by their parents, and they're like, I don't want to be here. I don't want to get better. And the thing is, a lot of times people say, oh, it's because it's ERP. No, the person doesn't even know ERP yet. We're not even at that stage. They're for whatever reason. And look, I was there. We all get scared. Getting better feels scary. But let's say, Janice, your son is like looking forward to this, really wants to get better. I would say at 11 sessions, because that's if it's weekly, Because I don't think you didn't say anything about it being intensive. If that's 11 sessions, that's almost 3 months. They should definitely, especially because they're taking medication, they should definitely be seeing, they should have some buy-in about why, he should stop giving into compulsions almost daily. I mean, he's going to still give into compulsions, but you should see a drastic reduction. He should have hope. He should be taught. The conversations with you, Janice, should be different. Like, I'm learning this. I don't need to do this anymore. I finally figured out that this is something that my OCD has me do, and I don't want to do it anymore. Like, after 3 months, I remember my mom say that. She's like, Chris's logic started to kick in a lot more. He was more relaxed on the drive up. He was looking forward to therapy. So I would say to have a heart-to-heart with the provider. Does he need a higher level of care? Does he need a different clinician? Is this treatment like top notch? Is these some of the best people in your area that you're able to attend? Because I would say after 11 sessions, there should be change, and it doesn't sound like you're getting that.
Yeah. So I immediately think two things. I'm like, is this provider qualified? And is the psychiatrist qualified, right? Just because someone's in ERP or on meds, they may not be on the right dose of meds, the right meds to move the needle for OCD, and same with ERP. So I want to ask those questions. And if both of those are yes, like, yes, they're an OCD specialist, yes, they're an OCD psychiatrist, I would think about level of care, right? So that is an indicator. We're actually, again, come to Chris's group this Friday, I keep saying Friday for some reason, Chris, but this Saturday, and make sure you come to that family group, because we are going to be talking about this, and I'm going to present a little, like, we'll send out a flyer afterwards on how you assess for levels of care and what that looks like, because that I've put together, just because I think it is important to know that this is an indicator we need a higher level of care. If somebody is going to ERP, outpatient ERP treatment, and they are consistently unable to do their homework, do their ERP outside of sessions, and they are not just not doing ERP outside of sessions, but they are engaging in rituals, so they're reverting back, we are guaranteeing that they're not going to move forward, right? That tells us something's going wrong. Now, that doesn't mean you have to jump to res. Maybe your provider could do 2 days a week. Maybe they could do 3 days a week. They could do like an individual, what we call IOP, or there's day programs in your area, or residential, which they may need. But again, what I'd be most concerned about out of this whole situation is, what is the therapist saying? The therapist should be talking to you about progress or lack of progress, what they think is happening, what they think isn't happening, and what their recommendations are, right? So that's a little bit of like a orange flag for me of like, and maybe they are, so it's a green flag, but like, I just would want to know, are they acknowledging this? Are they pointing this out? Are they concerned about it?
Yeah, I always have that talk with my clients. I usually am the one initiating it. If something's not working, I'm like, hey, this is what I think needs to happen.
And I tell all of our trainees, I'm like, you should be talking about levels of care and termination on day one with the patient, right? Because we want patients to know two things. Number one, in terms of termination, OCD treatment is time limited. It is short. It's goal oriented. These are not patients we keep on our caseload for 4 years, right? Like, we're doing something wrong if we have this caseload of patients that are just chatting with us, right? We are doing specialized, goal-driven, CBT specific interventions. And number two, you should be talking about levels of care at intake, because I want patients to know that, like, this is the treatment that works for OCD, and it works for a certain severity level. If your OCD is too severe, it doesn't mean ERP doesn't work. It just might mean that our level of care might not work. And so I always will say, we're always going to assess for that. We're always going to be looking at it. And if we are not moving the needle, we are going to sit back, recalibrate what we need to do so that we can, right? Because you want people to know a level of care discussion isn't a failure discussion. It doesn't mean they've done something wrong. It just means that their severity is too high to be treated at this level, right? It's kind of the difference of like, oh, I sprained my ankle. Can I run to Walgreens and get an ACE bandage and wrap it for a week? Or do I have 3 fractures that need a cast, right? The cast, I need to go get an x-ray. I need to go to a doctor. I can't just do that at home. The intervention looks different depending on the severity of the illness.
Yeah. And I always say, like, we can't take baby aspirin for a gunshot, right? Like
Exactly.
a gunshot wound. Like, we got to get the right dose. I just wanted to shout out Meredith, a new viewer who found us, and a grandmother. My grandma was so sweet to me during my treatment. Well, she wasn't at first when she didn't understand it, but when she started to understand it, she was a sweetheart. So shout out to grandmas. I'm so excited that Lewis has said that 100% engagement in OCD was a huge success for them. Acceptance and commitment therapy is a great treatment. If you go, I think this came up when we put up the guidelines, make sure to look at it. I know that, DBT can be helpful as well. Some people are, saying their morals as well helps. But I wanted to put this question up. So Anna says, it's very hard to find a therapist who can motivate my teenage kids to do their ERP, especially when they don't include parents in the process. My 16-year-old hasn't been in there for 2 years, still struggling. Not sure what's going on. Change therapists often. The reason I wanted to bring up this question is it kind of goes back to what we were just saying to the last question, but also when do you as a clinician know that, like, if you're working with a teen, like when to bring in the family involvement, educating the family. We had Victoria, it was super cool to have her on last week from OCDI, and she really talked about the importance of family aspect of therapy.
Yeah, I mean, with a 16-year-old, family should be actively involved. Does that mean you're going to be in every single session? Probably not, if the patient, especially if they're more independent and they don't really want that. But at the end of the day, they're a minor, they live in your roof. I need to be keeping you posted on what's going on, what they're working on, and how to support them at home, because at the end of the day, they live with you. So, you need to know how you can support, not enable, how you can build confidence and validate, but not give in, right? There's a lot of things that we need to be working through with you. You do want to find a clinician who's licensed in your area. So, I think that is really important. That is a part of our regulations and expectations as clinicians as well. And then, of course, you can email me. I don't know what to say, but I'm happy to help navigate this for people, just because sometimes, depending on where you're at, I'll know some providers in the area I can recommend. But feel free to look at reaching out to somebody you trust, to somebody who is an OCD clinician. I have yet to ever meet a OCD clinician who I trust and respect, who doesn't give time to help get people the right resources, the right referrals into the right places, right? We are all willing to do that because we know how important that is. So reach out and seek support and look into that.
I just wanted Patrick just said hi. So I wanted to put that
out there. You. See you next week.
I get at this question a lot. Does OCD, I think a lot of clients are afraid because sometimes the interventions in ERP is to start to allow thoughts to be there or bring them on yourselves. And I hear a lot of times, do thoughts manifest? How do you talk to somebody about the difference? Because once again, going back to our original OG at the start of the hour conversation, I think a lot of people are looking at coaches on manifestation and things. And then people with OCD are like, oh my God, am I manifesting these horrific things because of my thoughts?
Yeah. So 2 things. Number one, I was texting with someone the other night that I was like, you remember that book, The Secret? I've never heard of using the secret method for OCD. I'm just going to think. I'm no longer going to think about it. And I'm going to tell myself this story isn't real. And I'm going to tell myself this doesn't matter. And boom, it's going to be gone. Not how OCD treatment works, right? It needs to be behavioral. Again, everybody with OCD has tried to talk themselves out of it, has tried to not think about it. The same goes for thinking about it more, right? Thinking about it more and no longer avoiding our scary thoughts and our scary content does not mean we are going to cause it to happen. And it doesn't mean we want it to happen, right? It's so important to remember that OCD is ego dystonic. It goes against our values, against our beliefs, against who we are as an individual. So these are not fantasies and desires. They're the complete opposite of that. And so we are not asking you to start wanting these thoughts, to get excited about the thoughts, to hope that they come true. We're simply creating an environment where the thoughts no longer scare you, where you can have thoughts that never become a trigger. And that's the goal of OCD treatment. And as we do treatment, I think most people think, well, if you ask me to start talking about it or thinking about it more, it is going to come true. Or the more I think about it, I'm never going to be able to move on. And so that's why I can't do it. It's actually quite the opposite, right? How do you think about something less? You actually think about it more. Right? You let it be there. You choose to do nothing about it. And then it goes away because it's bored. It can't, right? But if when we have a thought, we try to not think about it and suppress it and push it down, we're actually empowering it. But we actually know that OCD treatment, ERP treatment, will actually make thoughts come with less frequency, less intensity, and will no longer be triggering. However, what I do want to say is that untreated OCD can kind of thought manifest, right? So if we are not treating OCD, yes, we will appropriately, we will continue to see these thoughts get louder, more of them. They'll be more bothersome, more intrusive, all the things.
Yeah, beautifully said. And that's why it comes back to make sure you're getting sources and information from good places. This really kind of goes to the conversation that we had. To summarize it, it was, unfortunately for Yesenia, her daughter spent months with the wrong therapist who refused to accept they weren't qualified. And I think that's what's so harmful is that, I mean, your family, just like my family, I mean, we were desperate to get me help. Your family was desperate to get you help. So we don't always know if we're in the wrong place. And that really is supposed to be our work as clinicians and our ethical guidelines. I've had people reach out, a big referral base I'll get is like family, like members of past clients, but the family member has something I don't treat. And they're like, my cousin cannot find a good therapist. You're a therapist. Can you please treat like her?
You're the best.
Yeah, you're the best. Can you treat her sexual assault? And I'm just like, look, unfortunately, like I want her to get the best care she can in that field. So therapists need to be honest about their limitations so they can find the right place. But I do want to say, Yesenia,
it is ethical as a therapist to be treating something you don't specialize in. And I agree, Katya put this earlier, but like there's not appropriate ethical standards and guidelines, and most clinicians don't look at it like that, right? And so I want you to be thinking about if something new is showing up and it isn't OCD and it's not fitting a typical ERP mold, but your clinician is really but like their specialty is on ERP, you should be thinking about pivoting clinicians and doing other work. You shouldn't stick with them to do everything. We cannot be a specialist in everything.
Yeah, beautifully said. And what I want to answer the second part, Yesenia, about how to help a 13-year-old feel motivated to do ERP at home. Don't make ERP seem like, like taking out the trash or cleaning up dog poop, right? Really it's the therapist role too, but really work with the therapist. I always try to figure out, especially in teens and preteens, how can we make the ERP fun? How can we make it part of their everyday life? How can we make it engaging? So, I had a client that there were certain trigger words. And so we found like a game, kind of like a Scrabble, but it was a different type of game with a lot of words. And so some of the words she didn't like, they weren't like blasphemous. They were just certain words around emetophobia. And so we found like games that she could play. And it was like the mom's involved. They're playing games each day. They're doing at least 30 minutes to an hour of fun game. And, the client was like, it doesn't even feel like ERP homework anymore. It feels fun. So a clinician who
I love that.
Yeah, clinicians that work with teens and work with young adults. Shout out to Dr. Oreen Wagner. She taught me a lot of this back in the day in the BTTI for pediatrics. But your daughter should see the value in it, but it should be something engaging that maybe you and her could do together. And it involves things that are everyday life. Going back to the earlier conversation, it has to be something she sees value in, or she's going to think of it as like another homework. And no kid likes homework.
No.
And
what I always say to parents in this situation is, what are things she's now avoiding doing with you that y'all used to do together that you really enjoyed, right? Maybe it's the ice cream shop, maybe it's going to the store, cooking together. It doesn't really matter, but that's what I want you to get back to. I want you to get back to fun and family time and engagement, but that might also be triggering, because that will be ERP. But our goal is that we don't wake up every day saying, here's the ERP I have to do. If that's what you're doing, guys, and like treatment constantly feels like just constant ERP and constant crisis and constant what's the trigger of the day, we are doing ERP wrong. ERP should get you to a place where you just get to live your life. You just get to be with mom and eat ice cream and cook and have fun and hang out with the dogs and do all the things, not I have to go do rigid ERP to be able to survive for the day. There's so many questions and comments. I love hearing from you guys.
Somebody said this about you.
Thank you, Anna. I love that. And I have a couple things we will never stop. We will never stop doing what we do. That's for sure.
I love Renee, so I just wanted to put this up, and she's speaking at OC. She's like,
yes, I love this. And thank you so much, Renee. You're the best. We love working together. A couple things. Someone asked about higher levels of care. There's a few of us in the country, so make sure that you are looking at an OCD specific program. Ours is OCDI Texas, so OCDITexas.com. There's a couple others that are OCD specific residential programs. That's my recommendation, is that you're really looking into that and not looking into a general residential program that says they treat OCD. And the difference is all of our programming from 8 a.m. to 4 p.m. every single day after hours, it's all OCD based. It's all OCD specialty. It's OCD providers. It's OCD equipped, trained, and staff. Lewis, I love your comment that we just have to talk about for a second. He says, mental compulsions had me stuck in that 40 to 60%. I'm finally back on track, and I've been here many moons before, but the relapse caught me on the hook. And I love this. I love that you on your own were able to say, what's keeping me stuck, right? Okay, maybe I'm doing ERP, but I'm still doing some compulsions. They just might be mental. And I know that if I don't let those go, I'm not going to see the full results. And this is so important, you guys. It is so important that we take ownership of all the things we may or may not be doing. Yes, you're doing it because it's so hard and because your thoughts are intrusive and they're terrifying, and that is actually still empowering OCD. So I love your willingness to talk about that and say that out loud. I'm seeing a couple of people talk about scrupulosity. So again, remember to check out our Faith in OCD conference coming up through the International OCD Foundation. And of course, y'all can always go to iocdf.org to learn more. And of course, go to our programs and conference specific page. I hope to see you all at the family group this Saturday, at OCD SoCal next weekend, at the Faith and OCD conference coming up, and all the different places. But Chris and I are always honored to share this space and do what we do. And that live call-in is going to come soon, whether it's through on our own or secondary or whatever, we will do it. Because I think it could be so fun, Chris, to have. I want to actually pitch a dual thing. I want to do a call-in, but then I also want to do a specific thing where people who have either done or use ICBT as an intervention, I actually want to do a live discussion about how it works, how it doesn't work. So I have a lot of questions. I want to better understand it. I know it's out there, and I know a lot of people feel like I should do ICBT instead of ERP. And to me, I don't promote that at all because the research is not there, but I want to learn. I want to better understand. I want to break it apart. But I don't want us to be divisive. And I've seen a lot of that lately in our field. And I think it's so important that we become less divisive and more cohesive when we talk about treatment, because our goal, I hope, for everybody doing this work is to get people better.
Yeah, definitely check out Allegra Caston's latest post. It really is we are all OCD providers first and foremost. If we all want to follow the treatment guidelines, we're all doing the same things then, right? So that's what it should be about. It shouldn't be certain fractions. Please, I want to say real quick, a shout out to this. Go to iocdf.org's calendar. There's a lot of really good things happening virtually and in and around your area. So check that out. On behalf of Liz McIngvale and myself, thank you all for being such a great group of people hanging out with us today. We had so many comments. We had so many questions. We had so many people from around the globe support us. We are here every Wednesday at 12 noon Eastern for Ask the Experts. These live streams have myself and Liz, or Kim Quinlan, or a psychiatrist, or other people that are prominent in our community, answering your questions, providing support. Always remember, you can go to IOCDF's YouTube, watch all the live streams that we've done in the past, because I think there's a lot of good information from experts around the globe that can really help you out. But I'm so glad you were here today, and I hope this conversation helped you further along in your OCD recovery. And we'll be back next week at the same time. And as always, I'll miss Liz. I'll see her at the this Saturday at the family group, but obviously
you'll see me for the next 4 weeks, because you'll see me this weekend, next weekend, and then it'll probably be time for our next live stream.
Yes. Take care, everyone. Make sure to head over to iocdf.org. There's so many good resources, and take care. We appreciate you. Bye.